Okay, Assalamu alaikum everybody. Good morning. So yeah, I had a very bad night last night. I watched Liverpool win with Muhammad. Oh, this isn't. Okay, thank you. Okay, so I'd like to thank Inas, of course, for asking me to come and speak on two subjects. One is, the first talk now is about bariatric surgery versus bariatric medicine. Why is that important? Well, actually, we need to go back almost 100 years to realize that there were people like Jocelyn, and this was at a time when type 1 diabetes was the big thing. Type 2 diabetes people didn't really know much about. And he said, from an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. So clearly, being fat or overweight is not a good thing in diabetes. And we then, in terms of bariatric surgery, probably the best set of data that we have, or had, was really from the SOS study from Sweden, where they published a series of papers looking at lifestyle, diabetes and cardiovascular risk factors after bariatric surgery. And what they showed that different procedures, this less so, but really this procedure, which is a Roux-en-Y bypass, produces significant loss of weight. So you can see here banding, vertical banded gastroplasty, and of course the Roux-en-Y gastric bypass produces significant amounts of weight loss, around 30%, 30-35%, but on average around 30%. And that's an important figure that I will come back to towards the end of this talk, because this is the gold, so-called gold standard. But losing weight, what impact does it have on recovery from diabetes? That's the most important thing. And again, this is data published a long time ago from open studies, and so therefore may be limited in terms of how we take away, what the message we take away. But the bottom line is that at 2 years, 72% reduction or recovery from diabetes. At 10 years, this was 36%. Compared to the controls. Even hypertension actually improved. But you can see the initial impact is high, and then this progressively becomes less. So now what we have actually are randomized studies which have compared bariatric surgery against intensive medical therapy, and we've got longer term outcomes, 5-year outcomes. And what do these show? Well, these are relatively small studies because they are randomized studies, but what you do see are medical therapy against sleeve gastrectomy against gastric bypass. You can see the numbers are relatively small, but what they show very clearly is that if you have just medical therapy, you will lose a little bit of weight, maybe 1-2 kilograms. Really, the major impact in terms of change in BMI from baseline comes with the sleeve gastrectomy, and particularly the gastric bypass. And of course, this has an impact on glycated hemoglobin, where you can see medical therapy, clearly you reduce HbA1c, but the most prominent and marked effect and maintained effect is with the sleeve gastrectomy and gastric bypass. And with that, actually, you have an effect in terms of the number of medications, particularly insulin, that these patients are on. So you can see here at baseline in terms of medical therapy, you've got 53% are on insulin. After month 60, which is 5 years, you can see 40% are still on insulin. However, look what happens in the gastric bypass and the sleeve gastrectomy. You can see 47% were on insulin, 45% on insulin. This at 60 months is markedly reduced to 12% and 11%, showing a much greater impact in terms of metabolic benefit with bariatric surgery. And this is actually HbA1c less than 6%. You might say, well, less than 6.5% should have been used, but 6% or 5.7%. But you can see 6% medical therapy, only 5% of people at 60 months had an HbA1c less than 6%. However, when you look at gastric bypass, this is 29%, and if you look at sleeve gastrectomy, it's 23%. And we now have actually, there's a paper published about 4 years ago looking at 12-year outcomes of gastric bypass in 1,156 patients. Essentially, what they did is compared 418 patients who underwent Roux-en-Y gastric bypass, 417 patients who were actually listed for Roux-en-Y gastric bypass but did not undergo the surgical procedure for various reasons, and then a population-based matched control who again did not undergo Roux-en-Y gastric bypass. And what you see is the following, that if you undergo Roux-en-Y gastric bypass, you see there's a spread of weight loss, but nevertheless consistent mean loss of 45 kilograms, which was kind of at 2-year follow-up. At 6-year follow-up, you can see you still have 36.3 kilograms less weight than baseline. And at 12 years, this again is maintained to 35 kilograms. So clearly, Roux-en-Y gastric bypass is working and working very effectively. You compare this to the group who had no procedure but were nevertheless overweight enough, sufficient enough to have a Roux-en-Y gastric bypass, and you see very little change, 2 kilograms. And in the matched group, no impact at all. So clearly this procedure is working, and we'd expect it to work. And of course, that is associated with diabetes remission with a HbA1c defined by a diabetes remission of less than 6.5%. At 2 years, 75%, at 6 years, 62%, and at 12 years, 51%, which you can see is substantially better than the SOS study, where there was actually, it was down to about 20%. But we ought to think about bariatric surgery actually beyond just an impact of weight loss. Because if you look at this study published from Brazil, this looked at people with BMIs, you can see, of around 32, 31. And what you see here is, despite the fact that these patients weren't particularly overweight, when they underwent gastric bypass, you can see a marked reduction in HbA1c, which is maintained out to 72 months, and diabetes remission in 88% of people. Diabetes improvement in 11% with no change in only 1%. So even normal weight individuals benefit from gastric bypass. And because I love neuropathy and we have some data, I thought I'd show you the benefits of bariatric surgery on neuropathy. Now there is, of course, people say that neuropathy sometimes gets worse because of deficiencies in certain key elements. But actually, what we've shown in 2 separate studies is in people who have bariatric surgery with and without diabetes. These are people just with obesity. Using our technique of corneal confocal microscopy, we showed actually that even obese individuals have evidence of mild early nerve fiber damage. But this is at baseline. At 12 months, there is a recovery or repair of nerve fibers in people who are obese. And we've also looked at patients who are diabetic, who are overweight, who've undergone bariatric surgery, and we again show improvements in nerve fibers at 12 months following bariatric surgery. Now, just this week, this has just been published. This, I think, actually is the bariatric surgeons fighting or marking out their territory, because they know that there's a lot of medical therapies that are coming out, And so they are now changed the guidelines almost. So what they are suggesting is, this is MBS, which is metabolic surgery. They are recommending it for individuals with BMI more than 35 kilograms. Before it was 40, regardless of presence or absence or severity of comorbidities. So they've moved the target down. And they base this on evidence. MBS recommended in patients with type 2 diabetes with a BMI less than over 30 kilograms per millimeter squared. And MBS considered individuals with BMI of 30 to 34.9 who do not achieve substantial or durable weight loss or comorbidity improvement using non-surgical methods. And then clinical obesity in Asian populations, which I think is applicable to the Arab population as well, actually they are now saying could be as low as 25 kilograms per meter squared. That means virtually everybody in this room would be eligible for bariatric surgery. And it goes on in terms of children and adolescents, so these are the latest guidelines for bariatric surgery. So, but we know that there are complications of bariatric surgery, and these are, of course, iron deficiency, vitamin B12 deficiency, vitamin D deficiency in considerable proportion of patients, which is why it's important to have follow-up of these patients. And there is, of course, surgical issues in terms of particularly a band slippage that you can see a reoperation rate. So are there alternatives? Well, you may be aware of this. This is actually the duodenal jejunal bypass liner. What is it? Well, this is really a plastic tubing that is inserted endoscopically into the duodenum and the jejunum and part of the ileum. And what it's been, this is the best study to date, actually, just been published about 2 months ago. About 230 patients randomized to either medical therapy or this liner. And essentially, what they show is that there is a change in weight. So there is greater weight loss. You can see compared to the normal standard medical care, around 10%. But you can see actually no difference in HbA1c. So there is this weight loss, no difference in HbA1c, and there is an improvement in lipids. So there is an improvement in total cholesterol and triglycerides. And then we come to medical therapy, which of course previously I would put a question mark over. Bariatric medicine, really? Do these agents work? Phentermine, topiramate, bupropion, orlistat? Yes, but not very effectively. However, we now, I think, are in an era of real, true bariatric medicine based on incretin therapies. And it really is as a result of evolution of not therapies for specifically targeted for weight, but actually therapies that were originally developed for diabetes. So really, these are the drugs I'm talking about: the GLP-1 agonists, the GLP-2 incretins, GLP-1 GIP agonists, and shortly to come, GLP-1 GIP amylin agonists. What do they show? Well, very clearly, if you look at data published for the once weekly semaglutide, you can see that starting with a body weight of just over 100 kilograms, you can see, and glycated hemoglobin actually in the normal range, so these are overweight, 5.7%, randomized to either receive semaglutide or placebo. What you see very clearly is placebo, you get this 2 kilogram weight loss in a trial because they had lifestyle and exercise. But semaglutide, clearly you're getting 16% weight loss up to 68 weeks. And more importantly, actually, what you're seeing is this, which is essentially more than 20 kilograms weight loss up to about 20%. And HbA1c, even when you have an HbA1c of on average 5.7%, you can see a 0.34% reduction, more so in the SEMA group compared to the placebo group. Then we have the latest, which is the twin cretin, tirzepatide GLP-1 GIP agonist in obesity, published this year. And what you see here is tirzepatide, 5 milligrams, 10 milligrams, 15 milligrams against placebo. Body weight, again, not markedly overweight. 100 kilograms is not huge. But what you see is very clearly huge reductions in weight, percentage body weight. You can see in the highest dose up to 20%. And percentage change in body mass index. And again, what is really, really important is this. More than 20% participants losing, more than 20% body weight. You're getting, numbers which are unheard of actually. And more than 25 kilograms, on average 25 kilograms, you can see again upwards of 20%. How do these two drugs compare? Well, I don't think this is a fair comparison actually, because tirzepatide higher dose was compared to semaglutide 1 milligram. However, what you do get is this study that was in diabetic patients, so semaglutide 1 milligram against the 3 different doses of tirzepatide. You can see that 1 milligram achieves a change in body weight of around 5 kilograms, but you can see that tirzepatide is 11 kilograms less than previously in obese individuals, but nevertheless in diabetic patients you are getting a dose-dependent reduction. And it's better than this, but of course we now have semaglutide, which is the much higher dose, which probably will be closer to the tirzepatide. HbA1c reduction, again you can see that actually despite the fact that they didn't lose much weight, you do get quite a good response in terms of HbA1c reduction, which is comparable. But look at the HbA1c reduction, almost over 2% in these higher doses. We then have tirzepatide against what arguably is the standard of management that we have at the moment, which is against insulin degludec. This is in patients add-on to metformin with or without SGLT2 inhibitors. So these are people with type 2 diabetes already on metformin with or without SGLT2 inhibitors who are randomized to either tirzepatide or insulin, and daily insulin degludec. And what do you see? Well, you see the following. Actually, insulin, you can see this is dose-adjusted insulin. Yes, reduces the HbA1c, but look at tirzepatide. Markedly more, greater reductions in HbA1c compared to even insulin once daily. And weight, as you'd expect, goes up with the insulin arm, comes down 5, 10, 15 milligrams. And again, HbA1c, this is where we're talking with the consequences of this. Look at this, HbA1c less than 5.7%, which is basically curing people with diabetes. You can see in the tirzepatide arm, 40%, over 40% of people are actually now cured of their diabetes, compared to, of course, very little in the insulin arm. And tirzepatide has also been compared to a titrated insulin glargine, again in the SURPASS study. And what do we see here? Exactly the same. Actually, you can see HbA1c, change in HbA1c reduces in the insulin arm, but much more, up to 2.45% in the tirzepatide arm. Weight, again, goes up in the insulin arm, comes down 5, 10, 15 milligrams. And again, the key feature is this. If you look at this, people who are cured of their diabetes, upwards of 40%, almost 50% of people have now remitted from having diabetes with HbA1c of less than 5.7. So my conclusions are that, fortunately or unfortunately, bariatric surgery, there's going to be less work for surgeons. Fortunately for us, there's going to be more work for physicians. And fortunately for the patients, we're going to have a lot more happier patients, I think. Thank you.